let's get on with our program. So we first have a talk on hypertension in pregnancy, the change of paradigm of hypertension in pregnancy. And this will be delivered by Dr. Carmaline Motha. She is a consultant physician and a senior lecturer attached to the Faculty of Medicine, University of Kelaniya. Over to you, Dr. Motha.
Thank you, Shehan. I would like to thank the Ceylon College of Physicians for inviting me to talk on a very timely topic, especially given the fact that hypertension in pregnancy remains an important cause of maternal morbidity and mortality, not just locally, but worldwide. I will first talk about the recent advances in managing hypertension in pregnancy, keeping in line with the subject of my presentation, followed by the physician's role in managing hypertension in pregnancy. As you are aware, it's our obstetric colleagues who mainly deal with managing hypertension in pregnancy. It's an area that's heavily guarded by our obstetric colleagues, and they do a wonderful job in doing so. But there are instances when we as physicians are called upon to manage these women. What are these instances? And that is what I'll be addressing in this section. And finally, I'll share with you a few words of wisdom in order to avoid some common pitfalls in management. Getting on to recent advances in managing hypertension, with regard to target blood pressure. Now, up until recently, the target blood pressure was considered 150/100 or moderate hypertension. Mild hypertension was not treated, and this was based on the pathophysiology of hypertension in pregnancy and preeclampsia. Treating mild hypertension was considered to further impair the uteroplacental blood perfusion and cause disastrous consequences to the fetus. However, a landmark trial that was published recently, the CHIPS trial, Control of Hypertension in Pregnancy, which was conducted by Maggie and her colleagues, which was an open, multi-center international trial involving about 1,000 women, which was published in the NEJM, changed this practice. They looked at less tight versus tighter control of hypertension. Less tight was defined as a diastolic blood pressure of 100. Tight control was a diastolic blood pressure of 85. And the primary outcome, which was fetal death and neonatal admissions more than 48 hours in the neonatal unit, surprisingly did not change. However, the rates of severe hypertension was significantly different. It was 40% in the less tight group compared to 27% in the tighter control group. And we know that the severe hypertension can cause harmful effects like intracerebral hemorrhage and pulmonary edema if not controlled adequately. And this changed the cutoff values for hypertension in pregnancy, and the latest NICE guidelines, which was published in 2019, brought down the blood pressure values, and they recommend to treat blood pressure if it exceeds 140/90, and they recommend the target blood pressures to be 130/85. So this was a significant change in the guidelines. What else is new? The categories of hypertension have now been simplified to hypertension and severe hypertension rather than mild, moderate, and severe. And the latest NICE guidelines no longer recommend a 24-hour urine collection to quantify proteinuria, but they recommend urine protein creatinine ratio or the urine albumin to creatinine ratio, which they consider to be more accurate and reliable. Up until recently, all women with preeclampsia were recommended to get admitted, but now a risk assessment should be carried out and an individualized approach should take place instead, and only women with certain risk factors are expected to be admitted. So these are some of the changes and recent advances that have come about. Everyone talks about a higher limit for blood pressure, but what about a lower limit? The 2019 NICE guidelines talk about a lower limit for women with chronic hypertension. They say that in women who are on treatment for chronic hypertension, to continue with existing antihypertensive treatment if it is safe in pregnancy, or switch to an alternative treatment unless the sustained systolic blood pressure is less than 110, or the sustained diastolic blood pressure is less than 70, or the woman has symptomatic hypotension. So this is a big step forward in the right direction. And this is something we need to reinforce to obstetric colleagues, to have a lower cutoff value for blood pressure, or else the uteroplacental perfusion is going to drop and there's going to be fetal compromise. And the American College of Obstetricians and Gynecologists had already endorsed targeting the diastolic blood pressure above 80. At least 70 millimeters of mercury should be the cutoff value. And we need to reinforce this and have a lower limit for the blood pressure. So please keep this in mind when treating women with hypertension in pregnancy. Now, over the last several years, there have been a lot of research with biomarkers to predict preeclampsia, which is the killer when it comes to hypertension in pregnancy. Though there have been several studies that have been done, none of the biomarkers have been shown to predict preeclampsia reliably in clinical practice. Nothing has been brought forward for us to use in clinical practice, and nothing has been brought to guidelines up to date. However, Chappell and her colleagues in the United Kingdom, this study changed the practice, and she concluded, her study concluded that in women presenting before 35 weeks, that with suspected preeclampsia, low placental growth factor had high sensitivity and a negative predictive value for preeclampsia in the next 14 days or 2 weeks, and is better than currently used tests. Following this study, a few other similar studies were performed, and the 2019 NICE guidelines recommend to offer placental growth factor-based testing to help rule out preeclampsia between 20 weeks and up to 35 weeks of pregnancy if women with chronic hypertension, who are the group of women at highest risk of developing preeclampsia, are suspected of developing it. So here is another for us where we have a biomarker that can predict preeclampsia, and if this is positive, very close surveillance can be carried out and we can reduce significant morbidity and mortality both in the mother and the fetus. And this has come into the guidelines, which we can now put into practice. Hypovitaminosis D in adult medicine is a hot topic these days, and it has also encroached into obstetric medicine. Most of you may be aware that pregnant women who are deficient in calcium in their diet, when repleted or given calcium, adequate calcium, the rates of preeclampsia have been shown to reduce. Researchers went a step further and looked at vitamin D levels and preeclampsia, and they found that women who have low vitamin D levels had a high risk of developing preeclampsia. These are some of the well-powered studies in the recent past that have shown this association. This systematic review, which was published recently, however, showed this association, but when they looked at vitamin D supplementation and the risk of developing preeclampsia, disappointingly failed to show a positive benefit. Therefore, further studies need to look at the exact link between vitamin D levels and preeclampsia, and further studies are underway to look at this. Getting on to the second topic that I wanted to discuss, the physician's role in managing hypertensive disorders in pregnancy. The first area that I want to discuss is severe hypertension. Now this again is very well dealt with by our obstetric colleagues because they are very experienced in managing this. This is not uncommon in clinical practice. But let me take a scenario. Let's take a woman who comes with a blood pressure of say 270 over 160 and there's fetal distress. And the obstetricians are not sometimes that patient and they want to deliver the baby immediately, and the anesthetist doesn't want to touch the woman because the risk of postpartum hemorrhage is high. And the obstetrician is quite agitated and will call upon the physician to bring down the blood pressure fast. Now, unfortunately, we have only a few drugs to play around with when it comes to severe hypertension. These are the first-line drugs. But if we know the pharmacodynamics, we can achieve what we want to. Labetalol, as you know, can be given intravenously as a bolus. The usual starting dose is 20, but remember you can go up to a maximum of 80. But remember that you can repeat it every 10 minutes. Nifedipine, though an oral drug, is very potent. The usual dose is 20 milligrams, but you can go up to a maximum of 40. But you have to wait for about 45 minutes for you to repeat it. Hydralazine, again, can be given intravenously, but you have to repeat it only after about, you can repeat it only after about 20 minutes. But you can go up to a maximum of 30. So what you can do is, you can start giving intravenous bolus of either labetalol or hydralazine, at the same time give nifedipine orally, so that it acts synergistically. And usually you can achieve what you want to. The other drugs that can be given for severe hypertension is diazoxide intravenously. And if you really want, you can give GTN intravenously, as well as sodium nitroprusside. But sodium nitroprusside, remember, can release cyanide, and there can be fetal toxicity. So just before delivery, you can give it if you really want to, but knowing very well that there can be effects to the fetus. But in very rare instances, you can use it. But these are the first-line drugs, and generally you can manage quite well with this if you know the pharmacodynamics. I would like to share with you 2 case studies to illustrate some of the complications of severe hypertension, mainly preeclampsia. A primigravida who delivered following severe preeclampsia a day ago complains of progressively worsening blurring of vision and severe headache. Her blood pressure is 150 over 100 while on captopril and nifedipine. What is the likely cause of her symptoms? Now here is a woman delivered 1 day ago due to preeclampsia but complains of progressively worsening blurring of vision and severe headache. A little bit unusual. Once you deliver, you expect the blurring of vision to get better and the headache. Any guesses? Posterior reversible leucoencephalopathy. I'm sure you've heard of this. This is not something that is unique to pregnancy. It can occur outside pregnancy. What is this? Now, cerebral autoregulation is supposed to maintain cerebral perfusion independent of fluctuations in systemic blood pressure. This is ensured by cerebral vasodilatation at times of systemic hypotension and cerebral vasoconstriction at times of systemic hypertension. But when a patient's blood pressure goes above this systemic cerebral autoregulation, then there is cerebral hyperperfusion and vasogenic edema. And it's the posterior part of the brain that is particularly susceptible to this because there is reduced sympathetic innervation compared to the anterior part of the brain. And this is the typical picture that you see on an MRI scan of the brain, which is the imaging modality of choice. And the patient classically presents with this headache, seizures, visual abnormalities that can take the form of lateral phase palsies as well as cortical blindness and altered mentation. And this is one of our patients who presented with severe preeclampsia at 32 weeks, HELLP syndrome, impaired renal functions, and the obstetrician very correctly delivered her on time. everyone was relieved, and the next day she complained of blurring of vision, and to everybody's dismay had this right lateral rectal palsy. Urgent MRI was done. All she had was posterior reversible leucoencephalopathy, and it was the cerebral edema that was probably responsible for this, the severe cerebral edema. Several weeks later, she completely resolved. What is the treatment for posterior reversible leucoencephalopathy? It is the meticulous control of blood pressure, and that only. And very importantly, to reassure the patient, and more importantly, to reassure the obstetrician. So this is just to illustrate how hypertensive disorders can present in less conventional ways. My second case study is a woman with severe preeclampsia who delivered and complained of shortness of breath and orthopnea on the first postpartum day. Examination revealed tachycardia, tachypnea, bibasal fine crepes, and hypoxia. So the obvious diagnosis was pulmonary edema. However, the echo was normal. So then, what was the diagnosis that we had to entertain? Non-cardiogenic pulmonary edema. So in women with preeclampsia, remember that there is endothelial dysfunction, much like what happens in dengue hemorrhagic fever. There is leakage of fluid into the alveoli. So all you need to do is prop up, give oxygen, and give IV diuretics liberally. And that you can do in the postpartum period without any problem. And you see a dramatic improvement in 1 to 2 days' time. Now the next area that I want to talk to you about, where the physician has a role, is the postpartum period. I would urge you to get involved in this area, which is an important aspect, and I will tell you why. The blood pressure target during the postpartum period is 150/100, and we have a few more drugs that we can use. Remember that it's best that if you can use a drug that could be given once daily, because the woman is breastfeeding and it is convenient for her. Enalapril is preferred therefore over captopril, but it's not readily available in the state sector. If one drug cannot control the blood pressure, then you obviously need to combine. So enalapril or captopril, nifedipine or amlodipine. So step 2 is a combination of one of the above, and step 3 is either atenolol or labetalol, a combination. Now, postpartum hypertension is very important. However, there's very little data, obviously, because once women are discharged, they don't come back for follow-up because they need to take care of a newborn baby. So there's very little literature worldwide. But one of the few prospective studies that is published is by Goel and his colleagues, where they looked at 1,000 women, and some very interesting data is available, where he found that among the women who were normotensive before delivery, 10% developed new or de novo hypertension postpartum. And among the women who already had a diagnosis of hypertension before delivery, 50% continued to have hypertension in the postpartum period. But mind you, this included women who had pre-existing hypertension. And the majority of patients develop postpartum hypertension between 42 to 72 hours following delivery, not in the first 2 days. And nearly all patients developed hypertension within the first week. And we do see this in our practice too, where this corresponds to the time during which the extracellular fluid relocates back into the vascular space. Now, this data is very useful and important to us because this is compounded by the fact that pregnancy is a hypercoagulable state, the risk being greatest in the puparia. The risk of thrombotic events substantially increases within the 6 weeks postpartum and normalizes after 12 weeks postpartum only. And the majority of pregnancy-associated strokes occur in the first 48 hours after delivery, and hypertension is the strongest risk factor. And studies have shown that cerebral infarction and intracerebral hemorrhage is high in the postpartum period. The take-home message is very clear: look for and treat postpartum hypertension adequately. Very often, once a woman delivers, blood pressure is not checked in the wards. And the study that I showed you very clearly showed, and few other studies have shown, that the blood pressure comes back to normal in the first 2 days. It goes up only after 48 to 72 hours. We need to tell obstetric colleagues this very clearly. Don't discharge the patients until 48 to 72 hours. The blood pressure can go up only after that. Keep the patient for at least 48 to 72 hours. Secondly, once you discharge the patient should be very clearly told, both verbally and written in the diagnosis card, if the blood pressure goes beyond a certain value, to come back immediately. And at 6 weeks, there should be a definite review. The data that I shared with you also showed that de novo hypertension can occur for the first time postpartum. So all women, irrespective, even women who did not have hypertension antenatally, should check their blood pressure postpartum, preferably weekly until 6 weeks. Why is postpartum hypertension common? The study that I shared with you, NSAIDs were used in 90% of women. Please avoid NSAIDs in the postpartum period. American College of Obstetricians and Gynecologists discourage NSAIDs in patients diagnosed with hypertension. Another important area, women who have had hypertension and whose hypertension has resolved completely postpartum, there's evidence to say that the risk of future hypertension, cardiovascular, cerebrovascular, and chronic kidney disease increases in the future. And this was our own data, which we presented in the Netherlands 2 years ago, where we found that women who had hypertension, the risk of future hypertension, ischemic heart disease, stroke, diabetes, and metabolic syndrome was significantly greater. So the take-home message is that women who had hypertension but resolved completely postpartum, that they should have an annual screening of blood pressure, lipid profile, and blood sugars. Few words of wisdom that I'd like to share with you finally. Remember that serum creatinine decreases in pregnancy, and the upper end of the normal range indicates impaired renal function. And in women with preeclampsia, oliguria may occur and should be considered physiological. Fluid therapy should not be given unless the serum creatinine is rising. And in women with severe, very early onset preeclampsia, I'm talking about women who have preeclampsia occurring at about 26 to 28 weeks. Look for features like SLE, underlying renal disease, or antiphospholipid syndrome, especially if there is underlying clinical features. And remember that somebody who delivers due to preeclampsia before 34 weeks, that itself is a clinical criteria for antiphospholipid syndrome. This will easily slip off the obstetrician's mind, but as physicians, we need to remember to refer to a hematologist. What is the future in the field of hypertension in pregnancy? American College of Cardiologists redefined blood pressure targets in adults. Will the same happen for our women? Reddy and his colleagues did this trial and looked at low blood pressure targets for women in pregnancy, and they found that preeclampsia and its adverse outcomes are seen at blood pressure targets below 140/90. So in the near future, it looks like blood pressure targets will be redefined in pregnant women too. That's all I have to say. This is a flower, which is the snowdrop, which symbolizes hope. I have put this for a reason. Let's hope that the paradigmal shift brought about by the new advances in the field of hypertension in pregnancy will bring about a better outcome for our mothers and their babies in the not too distant future. Thank you.
There is one question that has come up. A listener is asking, the national guidelines suggest that high-dose calcium is advocated antenatally. You spoke of vitamin D. What is the effect of calcium with regards to hypertension in pregnancy?
So I would like to say that what the evidence has shown is that calcium is given for various reasons in pregnancy. One is because the mothers need adequate calcium in order for preparation for lactation. But the other important reason is to prevent preeclampsia. But what evidence has shown is that in order to prevent preeclampsia, you need at least 1000 milligrams of calcium. But most of the time, what is given in as antenatal supplementation is not 1000 milligram, but a much lesser dose. It's 500 milligrams. So I think our antenatal guidelines should really the 500 milligrams is adequate for in order for as a supplement for to prepare the mother for breastfeeding, but not as to prevent preeclampsia. So I think this is something that we should look at actively, and our antenatal program should really take this forward and should recommend an increased dose if they are to prevent preeclampsia.
What is the effect of aspirin, especially in people who are prone for abnormal glycemia in prevention of hypertension and preeclampsia? Yes.
Yeah, so aspirin prophylaxis is given at a dose of 150 milligram in women with high risk factors for preeclampsia, but you're also asking with abnormal glycemia. So in type 1 and type 2 diabetic women, aspirin prophylaxis is advocated because they are at high risk of developing preeclampsia, but not in women with gestational diabetes mellitus.